Hi everybody, and welcome to our module on bilirubin. Before we talk about bilirubin, let's review the topic of bile. Bile is produced in the liver and then it is stored in the gallbladder. Then it's secreted into the duodenum after meals to help with absorption of fats. Bile is made up mostly of water, but it also contains phospholipids and electrolytes. And from a physiology point of view, the most important components of bile are the bile salts, which are necessary for lipid absorption. I talk about these in the module on bile. And then what we'll talk about in this module is bilirubin, and bile is the mechanism by which bilirubin is excreted from the body. On the left side of the screen is the structure of a heme molecule like you can find in hemoglobin. You can see that it has iron in the middle and it's surrounded by 4 nitrogen-containing rings. If you remove the iron from heme and you break one of the bonds between the rings, you can get the structure shown on the right side of the screen, which is bilirubin. And I show you this to help you remember that bilirubin is really just a modified version of heme. And anytime we're talking about metabolism of bilirubin, we're really talking about the way heme is broken down and metabolized in the body. Bilirubin has a brown yellowish color, and if you've ever had a bruise under your skin and seen it turn colors from the dark red to a yellow color, the reason for the yellow color is because bilirubin is being produced from the breakdown of heme. Now that we understand that bilirubin is really just a modified version of the heme molecule, let's talk about heme metabolism in general. So most of the heme that is broken down and metabolized in our body is heme that is released from old red blood cells, although some also comes from myoglobin, which is found in muscle, and cytochromes, which are used in enzymes in the liver. Released heme is engulfed by macrophages, which then metabolize it first into biliveridin and then into bilirubin. So let's look at this pathway at the bottom of the screen. So the heme structure is metabolized by an enzyme called heme oxygenase into biliveridin, which has a green color to it. And you can see that it's another 4-ring structure very similar to heme. Then there's an enzyme called biliveridin reductase, which converts biliveridin into bilirubin, which has a brown or yellow color. And once again, bilirubin, just like biliveridin and heme, is another 4-ring structure. These are all variants on the heme molecular structure. Bilirubin has relatively poor solubility in water, so once it's synthesized by macrophages, it needs to be carried by albumin to the liver, where it undergoes the next steps in metabolism. Once bilirubin reaches the liver, it is conjugated to a molecule of glucuronic acid. Conjugation means to add another molecule to the chemical structure of bilirubin, and the molecule that's added is called glucuronic acid. This is its structure on the bottom of the screen here. It's a 6-carbon structure like glucose, that's why it has the word gluc in its name. And you can see that glucuronic acid has lots of oxygens in it. This makes it very polar and very soluble in water. So when you add glucuronic acid to bilirubin, the bilirubin will become soluble in water. So you begin with so-called unconjugated bilirubin, and you add molecules of glucuronic acid to create conjugated bilirubin, which is now soluble in water. And you can see that this conjugated bilirubin molecule I've shown here has 2 molecules of glucuronic acid attached. They've been attached to these carboxylic acid groups here. This makes this a molecule of bilirubin diglucuronide. The enzyme that catalyzes this reaction is called uridine diphosphoglucuronil transferase, or UDP glucuronil transferase. So I've summarized these points on the screen here because they're very important. Bilirubin UDP glucuronil transferase, which I will call UGT going forward, adds glucuronic acid molecules to bilirubin to produce more water-soluble compounds. If it adds 1 molecule of glucuronic acid, it will create bilirubin monoglucuronide. If it adds 2 molecules, like I showed you on the last slide, it will create bilirubin diglucuronide. And the reason this is done is because it increases the water solubility of bilirubin so that bilirubin can be excreted in the bile, which, as I told you before, is made up mostly of water. Once bilirubin reaches the intestines, that is not the end of the story for heme and bilirubin metabolism. In the intestines, there are 2 conversions of bilirubin that are carried out by bacteria. The first conversion is back to unconjugated bilirubin. In the distal small intestine and colon, there are bacterial enzymes called beta-glucuronidase enzymes that unconjugate the bilirubin. Once it is unconjugated, bacteria can convert the unconjugated bilirubin into a structure called urobilinogen. This also occurs via bacterial enzymes in the intestines. At the top of the screen, I've shown the chemical structure of bilirubin. At the bottom of the screen is the structure of urobilinogen. You can see that the molecules look very similar. The only difference is that this double bond in bilirubin has been removed so that it's a single bond, but both structures have 4 rings, and both structures are really just variations of heme. And when you hear people talking about bilirubin and urobilinogen, they are really just talking about heme being modified so it can be excreted from the body. Once urobilinogen is synthesized by bacteria in the intestines, there are 2 potential fates for this molecule. The first potential fate is excretion in the feces. This is what happens to most of the urobilinogen molecules in your intestines. They get converted into a related substance called stercobilin, and this is the substance that makes your stools dark. The second potential fate is reabsorption by the intestines. This happens to a minority of the urobilinogen molecules in the intestines. Most of the urobilinogen that is reabsorbed is taken up by the liver, but a small amount is excreted in the urine. When it is excreted in the urine, the urobilinogen is converted into a substance called urobilin, and this is the substance that makes your urine have a yellow color. On the screen here, I've shown the chemical structures of stercobilin and urobilin, and you can see that they have 4 rings just like heme, and they are variations on the heme bilirubin structure that we've been talking about in the last few slides. So this slide depicts the entire process of bilirubin metabolism. We begin with unconjugated bilirubin that comes from heme breakdown. The liver conjugates that and excretes it in the bile. Bacteria have those beta-glucuronidase enzymes which will convert the conjugated bilirubin into unconjugated bilirubin. The bacteria will then further convert the unconjugated bilirubin into urobilinogen. Urobilinogen can become stercobilin, which makes your stools dark, but some of it gets reabsorbed. Most of the reabsorbed urobilinogen goes back to the liver, but a small amount goes into your urine, and that's what gives your urine the yellow color. It is that structure, urobilin, found in the urine, coming from urobilinogen in the intestines. The way we measure bilirubin levels in the serum is via a lab test called the Van de Berg reaction. In this lab test, bilirubin is coupled with a diazonium salt, and this forms a colored complex. And using the colored complex, you can measure the amount of bilirubin that is present in a serum sample. Serum conjugated bilirubin is soluble in water, as we have discussed. This means that it can directly undergo the Van de Berg reaction in aqueous solution. Serum unconjugated bilirubin, as we have also discussed, is not soluble in water. So before it can undergo the Van de Berg reaction, it has to be mixed with an alcohol. Then you can add the Van de Berg medium and carry out the Van de Berg reaction. Therefore, when you measure bilirubin this way, it is called indirect bilirubin because it is unable to directly undergo the Van de Berg reaction. So clinically, you will hear people talk about direct bilirubin and indirect bilirubin, and what they are talking about is the Van de Berg reaction. Indirect bilirubin means unconjugated bilirubin, and direct bilirubin means conjugated bilirubin. And the way I've always remembered this is to just remember that indirect goes with unconjugated. In and un go together, and then you can always keep it straight and know that when someone mentions indirect bilirubin, they are talking about unconjugated bilirubin. You can also detect certain components of bilirubin metabolism in the urine using a urine dipstick. This is a drawing of a urine dipstick on the screen. You literally dip it into the urine and it can detect the presence of certain substances, including bilirubin and urobilinogen. Now, bilirubin will only appear in the urine if it is conjugated because, as we have discussed, unconjugated bilirubin is not water soluble. And normally there should be no conjugated bilirubin in the urine. In other words, normally it should be absent. However, in certain pathological states, the levels of conjugated bilirubin in the serum can rise and it can spill into the urine, and then you'll be able to detect it with a urine dipstick. Urobilinogen is normally present in the urine in a small amount. As we talked about before, it gets converted to urobilinin. That's what gives urine its yellow color. So normally there's a small amount of urobilinogen present in the urine, and you can detect that on a urine dipstick. If you have high serum bilirubin levels, you will develop jaundice. Jaundice is yellowing of the skin, conjunctiva, and mucous membranes from high bilirubin levels. One of the first places you can often see jaundice is in the eyes. You will develop scleral icterus. I'll show you a picture of that in a minute, which is one of the earliest signs. Another one of the earliest signs is seeing jaundice under the tongue. If you ask patients to lift up their tongue, you can see yellowing of those mucous membranes. A normal total bilirubin level is less than 1 milligram per deciliter, and jaundice usually doesn't occur until it's greater than 3 milligrams per deciliter. Shown on the screen here is a picture of a man with jaundice. You can see that his entire face is yellow, and when you meet patients on clinical rotations with severe jaundice, you will see that they are bright as the sun. Their skin is almost glowing from the jaundice. I've also zoomed in on this man's eye so you can see that there is scleral icterus, meaning the white sclera of the eye have turned yellow from high levels of bilirubin. You also can get very dark urine if you have high levels of bilirubin in the serum, but this is only going to occur if you have elevated conjugated bilirubin, because only conjugated bilirubin is water soluble and capable of being spilled into the urine. You can have very high levels of unconjugated bilirubin and your urine will not turn dark because unconjugated bilirubin is not water soluble. Now, just as a reminder here, dark urine is not unique to elevated conjugated bilirubin. You can also see it in a number of other conditions. For example, in rhabdomyolysis, you spill myoglobin into the urine. That can make it dark. Hematuria of any cause can give dark urine, and in clinical practice you will commonly see dark urine in patients who are very dehydrated. Their urine is highly concentrated and can look dark. Usually not as dark as in this picture, but it can look darker than normal. Now let's talk about how we assess bilirubin metabolism clinically, and we do this using 3 different measurements. The first measurement is the serum bilirubin measurement. We measure the total bilirubin and the breakdown into direct and indirect bilirubin levels. The second measurement is the urine urobilinogen. Normally there is a small amount that you can detect in the urine. And the third measurement is the urine bilirubin. We can measure the conjugated urine bilirubin, and normally this is absent. For step 1 of your boards and for clinical practice, you're going to need to use those 3 bilirubin measurements to determine the cause of hyperbilirubinemia in a patient. And we'll talk about this in the next few slides. And in general, there are 4 causes of elevated bilirubin. The first one is hemolysis. The second one is biliary obstruction, which is also called cholestasis. The third one is liver disease. And then finally, there are special causes, which we'll talk about at the end of this module. Hemolysis is one of the main causes of hyperbilirubinemia. If you have hemolysis or a large hematoma present that is being broken down, you will have an increased amount of heme metabolism occurring in the body. This will raise the serum level of unconjugated bilirubin. Macrophages will break down all that heme and raise the amount of unconjugated bilirubin in the serum, and you will send too much bilirubin to the liver. It will overwhelm the capacity of the liver. That's why the level of unconjugated bilirubin rises in the plasma. You won't have any bilirubin in the urine because unconjugated bilirubin is not water soluble and it can't cross the glomerulus. It's bound to albumin. So if you do a urine dipstick, you will see no bilirubin in the urine in patients who have hemolysis. You will see an increased amount of urobilinogen in the urine because more bilirubin is being metabolized from the liver, and this leads to more urobilinogen. If we go back to our overview slide here, what's happening in hemolysis is that the body is being overwhelmed by unconjugated bilirubin from the breakdown of all that heme. Therefore, the serum level of unconjugated bilirubin will rise. None of this bilirubin can cross into the urine because it is not water soluble, so you won't see any bilirubin in the urine. As this unconjugated bilirubin is metabolized, it will raise the amount of urobilinogen in the intestines, which will therefore raise the amount that is reabsorbed, and some of that reabsorbed urobilinogen will go into the urine. Therefore, you will see an increased level of urobilinogen in the urine on urine dipstick in patients who have hemolysis. The second general cause of hyperbilirubinemia is biliary obstruction. Cholestasis is the lack of bile flow, and if bile can't flow into the duodenum, then you cannot excrete bilirubin. This can occur because of extrahepatic obstruction like a gallstone or a pancreatic mass. There are also some intrahepatic causes of cholestasis. Disease processes like alcoholic liver disease or viral hepatitis tend to clog up the intrahepatic bile ducts, and they can also lead to cholestasis. In cholestasis, conjugation occurs normally, but excretion is impaired. Therefore, you see a rise in the direct or conjugated bilirubin level. This is in stark contrast to hemolysis, where it was the indirect or unconjugated bilirubin level that began to become elevated. Besides an elevated direct bilirubin level, some other findings that can help you identify biliary obstruction include a cholestatic liver function test pattern. I talk about this in more detail in the bile module, but this occurs with a very marked increase in ALK phos, a much greater increase in the ALK phos level than the increase in ALT and AST levels. And then another finding you can see in biliary obstruction is clay-colored stools. You lack stercobilin in a biliary obstruction, therefore the stools will be clay-colored or pale because recall, as I told you before, stercobilin is what gives your stools their dark brown color. What you will see in the urine in cases of biliary obstruction is dark urine. That's because we have an elevated serum level of conjugated bilirubin, and conjugated bilirubin is water soluble. Therefore, it will cross the glomerulus, spill into the urine, and make the urine dark. In addition, you will see absent urobilinogen. That's because no bilirubin is making it to the intestine in biliary obstruction. Therefore, there's a loss of formation of urobilinogen. If we go back to our overview slide here, what's happening in biliary obstruction is that conjugated bilirubin is being formed, but it cannot make it out into the intestine. Therefore, it is spilling into the serum to give you a high level of conjugated bilirubin. This is water soluble, so it can cross into the urine to give you dark urine. In addition, because you do not have bilirubin flowing through the intestines, you lose your stercobilin and your stool becomes pale. It cannot become dark brown because it doesn't have stercobilin. The third general cause of hyperbilirubinemia is a primary liver disorder, and this is one of the more frustrating causes to understand as a student. It would be nice if liver disease caused a direct or indirect hyperbilirubinemia, but it doesn't. It often gives a mixed increase of both direct and indirect bilirubin levels. Bilirubin fractionation is unreliable for diagnosing liver disease as a cause of hyperbilirubinemia. The usual finding is an elevated total bilirubin level that is increased with a mixed increase of the two fractionated forms of bilirubin. When patients have primary liver disease, you are not going to make the diagnosis by looking at the bilirubin abnormality. What you're going to do instead is look at the liver function tests, antibody tests, imaging, or a biopsy. The bilirubin fractionation is unhelpful. Some primary liver diseases give an unconjugated hyperbilirubinemia. This occurs in liver diseases where there's lots of hepatocyte damage. If you damage the hepatocytes so much that they can't conjugate bilirubin anymore, then you will see a rise in the unconjugated bilirubin level. And this happens in patients who have chronic hepatitis or advanced cirrhosis. Basically, they have fried their liver so much that it cannot carry out the conjugation function any longer. Other liver disorders cause a conjugated hyperbilirubinemia. This occurs when liver disease leads to intrahepatic cholestasis. Some liver diseases have prominent damage to the bile ducts, and they plug up the bile ducts inside of the liver. You can see this in viral hepatitis and alcoholic hepatitis and non-alcoholic steatohepatitis. In reality, many liver diseases have elements of both hepatocyte and intrahepatic bile duct involvement, and this is why fractionating the bilirubin into direct and indirect is not helpful for making a diagnosis of a primary liver disease as the cause of hyperbilirubinemia. Urobilinogen levels in the urine are also variable and unpredictable in primary liver disease problems. Early in liver disease, you can see an increase in the urobilinogen in the urine. That's because urobilinogen is absorbed from the intestines as usual, but it's not being properly excreted in the bile, therefore it spills into the urine and raises the urobilinogen level. Late in liver disease, you can see a lack of conjugated bilirubin going to the intestines. This leads to less formation of urobilinogen and therefore less urobilinogen in the urine. So for this reason, it's very difficult to predict that for a patient with a given liver disease, what will happen to their urobilinogen level in the urine. This slide shows a table, as you can find in many textbooks and board review books, listing the lab findings associated with hyperbilirubinemia of different causes. When hemolysis is the cause of hyperbilirubinemia, the hallmark is an indirect hyperbilirubinemia. The urine bilirubin level will be normal, meaning none will be detected, and the urobilinogen level will be increased, as I described previously. When there is biliary obstruction, the hallmark is a rise in the direct bilirubin level. Direct bilirubin is water soluble, so it will cross into the urine. You will see an increased level of urine bilirubin, meaning the urine will turn dark, and you will see an absence of urobilinogen in the urine. And then, as I just described, in primary liver disease, the elevation of bilirubin is usually of a mixed type, both indirect and direct. The urine bilirubin is usually increased because there is usually some direct bilirubin rise in the serum, and the urobilinogen level is variable depending on whether it is early or late in the course of liver disease. So hemolysis, biliary obstruction, and liver disease are the three major causes of hyperbilirubinemia, but there are some more rare special causes, and you need to know these especially for step 1. So we'll go through all the causes listed on this slide in the remainder of this module. Rifampin is an antibiotic that is sometimes used to treat tuberculosis, and probenecid is a drug that can be used to treat gout. And both of these drugs have hyperbilirubinemia as a well-described side effect that occurs in a small number of patients. Both of these medicines can compete with bilirubin for uptake by the liver, so therefore they can blunt the liver's uptake of unconjugated bilirubin, and they can cause a mild increase in the unconjugated bilirubin level, and also, of course, the total bilirubin level. Importantly, all the other liver function tests will be normal, and when patients present to clinic with a rise in the bilirubin level, looking at the med list for one of these drugs is one of the first things that's usually done. Gilbert syndrome occurs when patients have decreased function of the UDP glucuronidase transferase, or the UGT enzyme, inside of their hepatocytes. Recall that this enzyme conjugates glucuronic acid to bilirubin so that bilirubin will become water-soluble and can be excreted in the bile. If we go back a few slides, this is the UDP glucuronidase transferase enzyme. It takes unconjugated bilirubin and adds molecules of glucuronic acid so that conjugated bilirubin, like bilirubin diglucuronide, will be synthesized, and this structure is much more water-soluble and can go out in the bile. One of the common reasons why patients with Gilbert syndrome have decreased function of this enzyme is because they have a defective promoter of the UGT gene. As a result, they synthesize less UGT enzyme than is normal, and they have a mildly decreased level of enzymes inside of their hepatocytes. Clinically, the findings in Gilbert syndrome include a mild increase in total and unconjugated bilirubin levels. Usually the level remains less than 3, and remember what I told you before, it has to be higher than 3 to cause jaundice. So usually these patients are not walking around with jaundice. However, if you measure the serum bilirubin level, you will find that it's mildly elevated. Patients with Gilbert syndrome can get jaundice, however, if something occurs to increase their bilirubin production. Remember, they are deficient in the enzyme that conjugates bilirubin, so if bilirubin production goes up, then the bilirubin level can get high and they can get jaundice. Things that increase bilirubin production include fasting, febrile illnesses, heavy physical exertion, stress, and menses. The mechanism by which these things cause a rise in bilirubin production is not well understood, but in all of us, these activities can raise bilirubin production. If our UDP glucuronil transferase enzymes are normal, that's no problem. We can metabolize the extra bilirubin, but in patients with Gilbert syndrome, they can't metabolize it and they can develop jaundice in the setting of these items I've listed on the screen. Other than occasionally developing jaundice, there are no serious clinical consequences, and Gilbert syndrome is generally a mild disease. It's often picked up incidentally when patients come in for an annual physical and their primary care doctor measures their bilirubin level. Crigler-Najjar syndrome is like a severe version of Gilbert syndrome. Babies born with this condition have severely reduced or absent UGT enzyme levels inside of their liver cells. As a result, these babies are unable to conjugate bilirubin effectively. The more severe type is called type 1. This usually presents in infancy. These babies have very high levels of unconjugated bilirubin, often greater than 20. They have jaundice that is obvious from looking at their skin, and they often die from bilirubin-induced brain damage, which is called kernicterus. We'll talk about that in a minute. This is often a fatal condition, and these babies usually don't survive. To understand kernicterus, you need to recall that unconjugated bilirubin is soluble in fats and lipids. Therefore, it easily crosses the blood-brain barrier. It can also enter the placenta if the mother has high levels of bilirubin in her serum. This means that unconjugated bilirubin can act as a neurotoxin. It can poison the basal ganglia and the brainstem nuclei, and this can be fatal for children with high bilirubin levels. You usually need a very high bilirubin level to develop kernicterus. Usually it needs to be greater than 25, but like I told you on the last slide, type 1 Crigler-Najjar often creates bilirubin levels that are higher than 25, and it often creates unconjugated hyperbilirubinemia. That's why babies with Crigler-Najjar can die from kernicterus. Newborn babies, especially preterm babies, are particularly vulnerable, and we'll talk about in a few slides how neonatal jaundice is a risk factor for kernicterus for newborn and preterm babies. There is a type 2 Crigler-Najjar syndrome which is less severe. Usually the bilirubin level is less than 20, and babies born with this variant of the syndrome have a reduced risk of neurologic consequences. And what you need to know about this type 2 syndrome, which is very rare for step 1, is that it's sometimes treated with two drugs, phenobarbital and clofibrate. Phenobarbital is a seizure drug or a sedative, and clofibrate is a lipid-lowering agent. So why would you give these two drugs to a baby with Crigler-Najjar? Well, it turns out that through mechanisms that aren't completely understood, both of these drugs can induce glucuronidation in the liver. They can cause more bilirubin to become conjugated. Therefore, they can lower the bilirubin levels by up to 25%. Now, in patients with a severe form of Crigler-Najjar, that's not going to help. Even knocking the level down 25% usually doesn't help. But in children with this type 2 less severe form, if you can knock the bilirubin level down 25%, you can prevent a lot of the neurologic complications, and therefore these two drugs are sometimes administered to children with this variant of Crigler-Najjar. Dubin-Johnson syndrome causes a conjugated hyperbilirubinemia, and this makes it distinct from Gilbert syndrome and Crigler-Najjar syndrome. Both of those conditions cause an unconjugated hyperbilirubinemia. The cause of elevated bilirubin levels in Dubin-Johnson syndrome is defective liver excretion of conjugated bilirubin. Patients with Dubin-Johnson have abnormal genes that code for substances called multi-drug resistance proteins. They get these names because they play an important role in resistance to chemotherapy drugs. But in the case of Dubin-Johnson syndrome, the multi-drug resistance proteins are necessary for bilirubin excretion into the bile, and if they are abnormal, the patient will be unable to effectively excrete bilirubin in the bile. Therefore, there will be a conjugated hyperbilirubinemia. The clinical findings, therefore, of Dubin-Johnson syndrome include, obviously, an increase in conjugated bilirubin. The total bilirubin level is usually in the 2 to 5 range, not that high, and at least half of it or so will be conjugated. Because conjugated bilirubin is soluble in water, you may see bilirubin in the urine. You won't see that in Gilbert syndrome or Crigler-Najjar because the unconjugated bilirubin is not water soluble. There's usually no pruritus in this syndrome, and why is that important? Well, if you have biliary obstruction, you can also see a rise in the conjugated bilirubin level, but in biliary obstruction, you also cannot excrete bile salts, and the bile salts deposit in the skin and cause pruritus. But in Dubin-Johnson syndrome, there's no pruritus because biliary salts are being excreted as normal. One of the key features of this syndrome to know about is that the liver turns black. And a classic description of a patient with Dubin-Johnson syndrome is someone who goes in for abdominal surgery unrelated to the liver. Maybe it's for appendicitis or gallbladder surgery, and the surgeon notes that the liver is black. That patient has Dubin-Johnson syndrome, and it's relatively mild, and they haven't been aware of it their whole life. It's being detected now at abdominal surgery when the surgeon looks at their liver. In general, Dubin-Johnson syndrome is a benign condition and no treatment is required. You can think of it as the equivalent of Gilbert syndrome, except that it causes conjugated hyperbilirubinemia instead of unconjugated hyperbilirubinemia. Rotor syndrome is very similar to Dubin-Johnson. These patients also have an increase in conjugated bilirubin. However, it's a milder increase and they don't have a black liver. That's what differentiates it from Dubin-Johnson. And I've showed you a normal colored liver here just to remind you that Rotor syndrome is different from Dubin-Johnson only in that it does not cause the black liver. Newborn babies can develop jaundice that is called neonatal jaundice, and there are several mechanisms by which the bilirubin level in newborn babies can become elevated. The first is that these babies just have high bilirubin levels because they have more red blood cells with a shorter lifespan, so there's more turnover of heme and therefore increased bilirubin levels in general. In addition, the UDP glucuronidase transferase enzyme takes several weeks to mature. When babies are born, it is immature, so it is not able to metabolize bilirubin as effectively as it will when the baby gets a little bit older. It takes about 14 weeks for the enzyme to reach its adult level of functioning. As a result, newborn babies often have an increased level of unconjugated bilirubin. They are producing more bilirubin and they are less able to metabolize it. If this is severe, it can lead to kernicterus, and preterm infants are at the greatest risk because they have very immature UDP glucuronidase transferase enzymes. Therefore, they're not able to metabolize bilirubin very well, and they can get very high bilirubin levels. Luckily, newborn babies with elevated bilirubin levels are identified, and there's a very effective treatment, and that is phototherapy. This involves exposing the newborn baby's skin to light of a specific wavelength. This is a picture of a newborn baby undergoing phototherapy. So why does it help to expose their skin to light of a specific wavelength? Well, it turns out that light can convert bilirubin into a substance called lumirubin. This is an isomerization of bilirubin. It converts it to something with the same chemical formula but a different structure, and that different structure is lumirubin, and it is more water soluble. This allows for excretion of bilirubin without conjugation. And newborn babies who have neonatal jaundice will have to stay in the hospital for a few days or sometimes a few weeks under the lamp like this baby here until their bilirubin level falls to normal and their liver is able to conjugate normally. For the final slide in this module, I'm going to give you my bilirubin algorithm for tackling problems of hyperbilirubinemia. When you're faced with a patient who has hyperbilirubinemia, either in a board question or clinically, the first thing you want to do is ask yourself, is the elevation in bilirubin isolated? Meaning, is it occurring by itself or is it occurring in association with other liver function test abnormalities? If the hyperbilirubinemia is not isolated, then you want to look at the other LFTs like AST and ALT and alkaline phosphatase. If you see an increase in AST and ALT that is much greater than the rise in alkaline phosphatase, that is called the hepatocellular pattern of liver function test abnormalities. I discussed this in more detail in the module on bile, but this pattern of LFT abnormalities occurs in many liver diseases. On the other hand, if the alkaline phosphatase is increased to a much greater degree than the AST and ALT, that's called the cholestatic pattern of liver function test abnormalities, and that's what you see when you have cholestasis or obstruction of bile flow, as can occur in gallstones and pancreatic masses. But the point here is that when the bilirubin level is increased in association with other abnormalities, you want to focus on the other liver function tests in order to make the diagnosis. On the other hand, if you have an isolated hyperbilirubinemia in the setting of normal liver function tests, then there is only a small group of disorders that can cause this. Clinically, one of the most common causes of this problem is hemolysis. For your board, you want to consider more rare conditions. If you have an isolated direct hyperbilirubinemia, that could be due to Dubin-Johnson syndrome or Rotor syndrome. If you have an isolated indirect hyperbilirubinemia, that can be due to drugs, as we discussed. Also Gilbert syndrome, Crigler-Najjar syndrome, and you can also see this in neonatal jaundice. But the point here is that the first thing you want to do is decide whether or not the bilirubin elevation is isolated or not, and based on that, it becomes relatively straightforward to work out the cause. And that concludes our module on bilirubin.